Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Ryan. How are you doing today?
Good to see you, my friend.
Good to see you again. So today I would like to talk about tuberculosis. One of the reasons is there was an outbreak in Kansas recently, which when you read about it, it doesn't sound like really an outbreak. It's just something that happened. And I can't tell you how many times I've been in public engagement type meetings downrange, and as soon as people start coughing, my skin starts to crawl. So I would really like to talk about tuberculosis and odds and treatments and etc.
Yeah, no, absolutely. Yeah. So, tuberculosis is kind of one of the great plagues, obviously, of humanity, and goes back many years. And we'd been making fairly steady progress globally in tuberculosis control. A lot of that was set back by the COVID-19 pandemic, just due to difficulties in doing case finding and so forth. But one of the big things that really made an impact on TB, both on the bad side and the good side, has been the HIV pandemic. HIV and tuberculosis have a very close interaction, and both in the United States and globally, during the darker times of the HIV/AIDS pandemic, tuberculosis rates skyrocketed, both in the United States on a relative basis, but particularly in sub-Saharan Africa. On the flip side, improved control of HIV, both in the US and globally, through programs like PEPFAR, has really made a big impact on both TB incidence and TB outcomes. But tuberculosis still remains highly endemic throughout much of the world. A large proportion of the Earth's population is infected with TB. That doesn't mean that they have active tuberculosis. It doesn't mean they have the disease, but that means that they have the bacterium in their body, and your immune system's holding it in check. And a lot of our screening is based on identifying those people and treating them in advance prior to developing active disease. So, the outbreak in Kansas City, or in the Kansas City kind of region, it was over the course of about a year, right? So it's kind of a slow motion outbreak, but, 67 cases in a single geographic region in the continental United States. It doesn't see a lot of immigration. It sees some, obviously, is a lot, right? Like when I was active duty and I was stationed in San Diego, at different times, I had a fairly active TB practice, and I was usually managing a few patients at any given time with active tuberculosis. But, San Diego is also, one of those kind of unique places where you have a wealthy region right next to a developing country. And so obviously, immigration from Latin America played a big role into our TB incidence in Southern California, but also, the other big countries were the Philippines, Nigeria, and Vietnam were along with Mexico, are kind of the big four places where we saw a lot of folks with tuberculosis in SoCal. But beyond that, there is a certain incidence of locally acquired TB among U.S.-born people that we do have to be vigilant for. Now, one of the things I think we do, quite well in the military is active screening for it. Whenever we all come into initial military training, regardless of what pathway we do, there is screening for tuberculosis infection, and that historically is with the PPD, with the skin test. More recently, we're using blood-based tests. Like the brand name is QuantiFERON Gold, but the generic term would be an interferon gamma release assay. So we have we're pretty good at identifying these folks and getting them on therapy early to prevent the progression to active disease. But it is still a big public health deal, and I think Kansas City reminds us that TB is not some thing that happens far off in the ether. It can happen at home.
Yeah, absolutely.
Yeah,
it happens pretty much everywhere.
It does.
Whenever two people are breathing on each other, yeah. Tuberculosis is a possibility.
Absolutely.
So what is it? Like, how does it transmit? How does it infect the body?
Yeah, TB is caused by, kind of classically, it's caused by a bacterium called Mycobacterium tuberculosis. And, mycobacteria are a relatively large genus of bacteria. And on some level, they're just bacteria, right? I mean, they're treated with antibiotics. The antibiotics are sometimes different than we use for other pathogens. And the treatment is often a little more complex than it is for like a sinusitis or what have you. But in the end, they're just bacteria. They tend to grow more slowly than other bacteria. So that's one of their unique features. And then they tend to stain under the microscope using a thing called acid-fast staining. So they're identified through a somewhat different technique in the lab. And they grow more slowly. So you have to, we tend to let these isolates grow for up to 6 weeks. Although TB, usually you'll see it grow within about 2. Or at least you'll start to see something within a couple of weeks. It may take longer to do the formal identification. TB is actually just one member of a larger family called the tuberculosis complex. Mycobacterium tuberculosis is, 99% of what we see globally, but there's a thing called Mycobacterium bovis, which is, as the name implies, is associated with cattle. It's one of the reasons we pasteurize milk. Tends to cause gastrointestinal TB from consuming unpasteurized milk. There's a thing called Mycobacterium africanum, which is found mostly in Africa, as the name implies, causes a disease. It's very similar to tuberculosis. And then there's actually, this is kind of a fun fact, a thing called Mycobacterium cannedii, which is probably the progenitor species of the other 3, including tuberculosis, which is pretty much confined to the Horn of Africa. But it's significant because we have a base in Djibouti, and Djibouti is kind of the galaxy's epicenter of Mycobacterium cannedii. It is not very common in non-Djiboutians. When you look at tuberculosis Djibouti is a former French colony. People born in France, when they get TB living in Djibouti, they tend to get like just regular TB, Mycobacterium tuberculosis. Whereas you see cannedii causing mostly gastrointestinal tuberculosis in people who are born in Djibouti. So it's kind of a neat fun fact that it's the ancestor of the others, but has some kind of distant operational relevance. I learned about this from a French Army medical officer stationed in Djibouti who had made himself into a bit of an expert into the disease because he'd seen a lot of it. But yeah, so TB is caused by a bacterium, widespread throughout developing countries, and obviously a fair bit of it brought in either through immigration or just through local transmission. And when I'm trying to screen people for TB risk who are U.S. born, the questions I tend to ask them are, any history of substance abuse? Have you ever been in jail? Or any contact with the kind of the correctional system. Actually, I took care of a guy in Kandahar who had was born in the South, kind of standard issue gringo like myself, who had worked before he joined the military, had worked in HVAC repair in the Alabama prison system. I'm like, okay, there we go. Homelessness, any periods of homelessness. And then obviously any known exposure to people with active tuberculosis. Those are the big categories where people get TB. And in the absence of those, your risk is relatively low. But a lot of people don't know your exposures, right? And certainly people in the although periods of homelessness and periods of incarceration are relatively unusual in the active duty military. Right. It's
debatable.
Yeah. I mean, it's not, it ain't zero, but it's not the most common thing. Right. But exposure to people with TB, especially if you've deployed to a TB endemic area, that ain't zero. Right. That ain't zero. And I tell people that, when I was stationed in Peru way back when, I would round most weeks on a tuberculosis ward at a large public hospital, Hospital Nacional dos de Mayo in Lima, and it's open bay, right? There's no negative pressure rooms. It is just a big open bay room with people with tuberculosis lined up in beds. And I never converted, actually. I never converted. And part of that is, I was wearing a mask. But the other reason is that they had good ventilation, sunlight, UV exposure and good ventilation actually really has a marked reduction in the risk of TB acquisition. And so if you're in a place that doesn't have negative pressure rooms and all of the things that we use for TB control in U.S. hospitals, there are other ways to control it. And one of them is sunlight and airflow. And that actually works pretty well. Yeah. So, yeah, go ahead.
What, at least from what I understand, tuberculosis, is it only through respiratory?
Not only. You can get it through consumption. So talk about Mycobacterium bovis, for example, which is basically causes tuberculosis, is often associated with consumption of, ingestion of something. So unpasteurized milk is one of the several reasons we pasteurize milk, is to prevent M. bovis transmission. But so you can get it through ingestion, but the great majority of it is through inhalation. So we inhale the bacteria, it forms a granuloma. There might be some associated lymphadenopathy. It's called a Ghosn complex. And then our immune systems contain it, right? And so, and this creates what we call latent tuberculosis infection, which, when we talk about TB outbreaks or you read about them in the news, it can be a little vague. Do we mean active disease or do we mean latent disease? Or latent infection, I can say, because by definition, if you have latent infection, you do not have a disease, you're not sick. And most people in the world who are infected with TB, what they have is a latent infection. And the thing we're trying to prevent is conversion of that to active infection. So if you inhale Mycobacterium tuberculosis, it gets in your lung, you get it under control. The things we see in most people is at some point within, a few months, you'll convert from a negative PPD to a positive PPD or a negative interferon gamma release assay like a quantiferon gold to a positive one. And what those things are measuring is cell-mediated immunity against M. tuberculosis. So it's like checking an antibody, but it's not an antibody because antibody-mediated immunity doesn't really play much of a role in our control of TB. So if you have that, if you are newly converted, you have the estimates are, and actually like Naomi Aronson at USIS has done a lot of this work, about a 10% lifetime risk of progressing to active TB. Half of that risk is in the first year or two. So when we find a new converter, we do want to get them on therapy promptly to treat latent tuberculosis so that they reduce that risk of progression. We can reduce that risk from 10% lifetime risk to less than 1% with treatment. If we don't know when you converted, which is true in a lot of places, like when you come into active military service, when you go into boot camp or you go to OCS or what have you, everyone gets tested, right? And so we usually don't have a prior negative, so we don't know when people converted. We still do offer those people therapy, even though that first half of risk may have come and gone, but they still have the rest of their lifetime risk. It gets a little gray when we start doing PPD checks on people who are in their 70s, right? Where they've outlived most of their lifetime risk and the toxicity of treatment might kind of outweigh the benefits. In those people, barring something extraordinary, like we're about to give them a drug that turns off their immune system, may or may not actually treat them. A lot of my practice nowadays, since retiring from the Navy, has been in transplant and transplant infectious diseases. And so for those folks, because we know the risk of TB reactivation with transplantation is very high, we treat everybody because we have no good way of really knowing, okay, did you really outlive your risk or not? And post-transplant tuberculosis is a nightmare. And so we're very aggressive in treating it. But like in the general population, if we randomly placed a PPD in an 80-year-old, I would probably smile and nod and make sure they had a normal chest x-ray and call it a day.
Okay.
Yeah.
All right. So either maybe not said 80-year-old, but I guess really anybody.
Yeah.
They come to me. I'm downrange.
Yeah.
I don't have an x-ray. I have an ultrasound.
Yeah.
Basic tools. They're complaining of cough for several weeks.
Sure.
And they're just, they want essentially cough drops.
Yeah.
And how do I get from that guy to You got tuberculosis.
To a tuberculosis diagnosis. And I will tell you, the operational environment is not going to be one where it's going to be very easy to diagnose TB. If simple chest radiography, if simple plain chest x-ray is available, first of all, I would say this: TB is rarely, not never, but rarely an emergency, right? I mean, there are some manifestations of tuberculosis. Most TB is pulmonary, but there is extrapulmonary TB, and certain forms of extrapulmonary TB can be emergencies, like tuberculous meningitis or tuberculous pericarditis. Those are emergencies, right? Most TB is rarely an acute emergency, maybe kind of a public health emergency, like we need to get this patient identified, isolated, and on therapy. But in terms of a acute life-threatening emergency with TB, you usually got some time. Ultrasonography and tuberculosis diagnosis is, I think, probably not terribly well validated. And, the classic findings of TB, the things you'd look for on a chest x-ray would be upper lobe disease, right? Upper lobe disease is one of those things that kind of alerts you to TB. What we call primary TB or acute TB, when people develop active disease shortly after initial infection, that can often be in the middle, in like the right middle lobe, and they tend to have more lymphadenopathy associated with it. So that can be a concerning finding, especially in a younger person who's otherwise healthy, who was recently exposed. Kind of the classic findings of upper lobe disease, cavitary disease, if you see a big old hole in the lung, those are things that should just, if you happen to see that person needs to be worked up for TB, right? There are times when I have a more compelling diagnosis for that kind of syndrome, but there's very few situations where I see a hole in an upper lobe of your lung where TB isn't the thing we need to eliminate. But most TB doesn't have the common decency to do that, especially in younger immunocompetent people. So, it's often non-cavitary disease. It's often chronic disease that's not resolving. Sometimes, quinolones actually have a lot of activity against tuberculosis. So sometimes if someone got levofloxacin or moxifloxacin and they transiently improved and they got worse again, that can be a useful sign, because monotherapy for, a week, they might feel a little better briefly and then they're going to feel worse again. And this is one of the reasons in TB endemic areas I try to kind of shy away from quinolones, because kind of partially treating TB is a pretty bad idea. So, I think ultrasound and clinical assessment, it's going to be very hard, just to be straight with you. I wish there were a better way to kind of identify that in an operational environment. And I think in someone with a chronic cough, at least trying to figure out if there's a way we can get them a proper chest x-ray at some point is useful. Also say this is not going to come up terribly often in the operational environment. There was, when I was in Kandahar, there was an exposure in a deployed unit that I helped work up and assisted with, and it didn't really turn into an outbreak, but it was certainly a large scale exposure, and everyone did fine. There were no real cases of active disease identified, but there were some cases of latent disease we got on therapy. So it does happen, but it's rarely like a medevac everybody kind of situation, right? It's when we have the opportunity, let's get people properly screened. Yeah. But the guy with the chronic cough, chest x-ray when you can get it, right? I mean, one reassuring thing is that, tuberculosis rarely gets better spontaneously. So, so if someone's cough is improving over time, that does shift the math a little bit. The other thing for kind of diagnosis of active disease is looking for these other symptoms. And the other symptoms classically are going to be night sweats, right? Fever during the day, maybe not, but like drenching night sweats. Like you gotta change your t-shirt if you slept with a t-shirt on at night because of that. Unexplained changes in weight, mainly weight loss, would be another one. Swelling of the lymph glands, lymph nodes in your neck and your armpit, those can be concerns as well, especially if it's relatively recent in onset. There is a tuberculous lymphadenitis, which is TB of your cervical lymph nodes. Actually has a name. It's called scrofula. which is one of those great old-fashioned medical names. And scrofula is actually a fairly common manifestation of TB in immunocompetent people. And I saw a fair bit of that on active duty.
Okay. Now, would you, since I don't have the right assessment tools, you essentially have what you have.
Right.
Until I can get them to somewhere else, would you just go ahead and put them in some kind of isolation protocol?
Yeah, I mean, I think the simplest way for the person with suspected TB is just have them wear a normal surgical mask. You know, that when people are kind of out and about, like when I have people with TB coming into clinic, I just have them wear a regular surgical mask. You know, and we do what we can to kind of minimize close contact, especially in an enclosed space with other folks. But when they're moving out and about, the N95 is more for us. Surgical mask is usually sufficient for them to kind of capture their own secretions and minimize the risk to others. Obviously, I would say anyone taking care of that person clinically should try to wear, you know, a proper N95 if available. But, you know, and then in terms of kind of how do you protect them, how do you protect others? You know, good ventilation is 90% of it. You know, if you're in a place where you can keep the windows open or what have you, try to do so. Try to maintain good airflow in whatever place they're in. We had in Afghanistan, you know, we had a few cases of airborne diseases. We didn't have an N95 in Kandahar, right? Or it was, pardon me, that's not what I meant. We did have N95s. We didn't have a negative pressure room. And so we would just establish, you know, places we kind of set patients aside, get good airflow, maintain a geographic distance between them and other patients to minimize transmission. And that works pretty well.
Okay. So we get them off to, I would say if they have an x-ray in an area that has tuberculosis, more than likely they would have, well, I guarantee they're more likely to have the medications than I will. But what is like the treatment regimen? Yeah.
So the classic treatment for active tuberculosis, and I should say, I mean, this is not a decision that I would ever impose on a medic in the field, right? This is a decision where, you know, you give us a call and we'll talk about it. Right. And we'll talk our way through it. Partly because some of the dosing is weight based too. And we need to, you know, kind of come up with the right way to do it. But if you decide, and if you find yourself in a position to treat TB, the classic regimen for the great majority of tuberculosis is a combination of 4 drugs. And as you and I talked about earlier, you know, it's kind of, you know, 4 drugs for 2 months, 2 drugs for 4 months. And there's some subtleties in that. And differences if it's cavitary versus non-cavitary disease and so forth. But the classic regimen is a combination of isoniazid, rifampin, ethambutol, and pyrazinamide. And then, you know, in general, you do that for 4 months. In practice, when you have susceptibilities back, you drop the ethambutol, you continue the pyrazinamide for 2 months, and then you drop down to just isoniazid and rifampin for the remainder of the regimen. And there's other steps involved, like if they have cavitary disease and when their smears clear, because you have to get serial sputum specimens on these folks to see when their smears turn negative, when their cultures turn negative, and that adjusts some of these clocks. But yeah, in general, 4 drugs for 2 months, 2 drugs for 4 months. Starting regimen is abbreviated often, at least in the U.S., as RIPE, rifampin, isoniazid, pyrazinamide, and ethambutol. The WHO regimens for that, same regimen, but they abbreviate it as HRZE. So if you're looking at, just to reflect differences in language. So if you're looking at some of the international guidelines, you'll see HRZE. That's the same thing as RIPE.
Okay.
Yeah.
All right. Now, I'm not sure if this is kind of geographically lined, but there is such things as multi-resistant drug resistance. So, I mean, is that just certain areas of the world that are more likely, or is it just you got the ACE card?
Well, there is. Whoops. My cat just tried to jump in my lap and didn't quite make it.
Yeah, jealousy.
Yeah. She doesn't like it when other people are paying attention to, or people aren't paying attention to her. So Yeah, so multi-drug resistant TB is certainly a global problem and not terribly common in the United States in the cases we see here, but it does exist, and I've seen cases. And when we describe something as multi-drug resistant, that has a formal definition. And generally what that means is that the TB is resistant to rifampin, is resistant to isoniazid, and often is also going to be resistant to some other kind of second-line drugs or other drugs out there. So part of the reason we start people on 4-drug regimens is to minimize the chances of this being a problem. So hopefully we'll have some active drugs on board, ideally more than one. But INH and rifampin resistance, because rifampin in particular is sort of the workhorse of these 4-drug regimens. Rifampin is the one that penetrates into cavities, penetrates into infected space, kills bacteria very rapidly. But the genetic barrier to resistance for rifampin with TB is pretty low. So we have these other drugs on board to bump off resistant mutants as they arise. So MDR-TB, globally, one of the big hotspots for it is actually the former Soviet Union. And so cases in Russia, in Ukraine, in Belarus, in many of the Central Asian republics. These are some of the, but not all of the global hotspots, both for MDR-TB and then XDR-TB, extensively drug-resistant tuberculosis, which implies that they're also resistant to quinolones like moxifloxacin and levofloxacin, aminoglycosides typically, or some other injectable drug for TB. So these are very difficult to treat. And I would say if you were deployed and you saw someone who was at risk for MDR-TB, that person should be encouraged to find a new place to hang out for a while we get them on therapy. So ways you can diagnose this rapidly, though. So globally, and this is not a thing you'd be packing along with yet, but we do have these these pieces of equipment, the basic PCR machines, in some deployed environments. You'd have to have the right kit, but it could be done. But there are PCR assays, and again, you're not going to have this in a prolonged field care environment, but that will detect on a sputum specimen both tuberculosis and rifampin resistance. And if you get a positive hit on both of those, if you get a positive hit on the TB, you have TB. If you have a positive hit on the rifampin resistance aspect of that, then we presume you have MDR-TB, because rifampin resistance is necessary for the diagnosis of MDR-TB. And generally, if you have rifampin resistance, you probably have MDR. I will say that MDR treatment has gotten a lot better in recent years. It used to be an extremely extended course of relatively toxic drugs, including IV drugs that we had to give to people. And that has changed a lot in recent years to the point where we can treat most MDR patients with all oral regimens. Not a thing we would need to do in the deployed environment. And not a thing that I would recommend starting in the deployed environment. But again, TB, rarely an emergency, right? Our priority in the deployed environment is ensuring the patient's stability, and then public health measures, masking, some degree of geographic separation from others to reduce the risk of transmission.
Okay. So you mentioned these drugs are not benign in themselves, that they do cause some kind of toxicity. Yeah. So what can be expected?
Yeah. So I think the situation we'd be most likely to find ourselves in on a daily basis is going to be treatment of latent TB. And then I'll talk about active TB as well. So for latent TB, there's a number of different regimens for it. The simplest regimen, but the one that's probably least likely for us to be able to implement while deployed, is a combination of isoniazid and rifapentine, not rifampin, but a closely related drug. And that is a large oral dose once a week for 12 weeks, right? So that's pretty quick, pretty easy. Pretty well tolerated by most younger people. I don't get to use it that much in my own clinic just because for whatever reason, it's not terribly well tolerated by people on dialysis, and that's a lot of who I'm seeing are people who are pre-kidney transplant. The main toxicities there are liver related. That being said, it's pretty unusual to have to actually stop latent TB therapy because of liver toxicity. And so if people's liver tests are pretty normal at baseline, and the ALT and AST stay less than 300 on therapy, and they feel okay, you can usually power people through that. Isoniazid can cause a peripheral neuropathy. And so when we give people isoniazid, we always give them pyridoxine, which is vitamin B6, and that basically eliminates that toxicity. So give isoniazid, B6, and rifapentine once a week. Now that's kind of the preferred option. In a lot of operational environments, it is actually, you got plenty of time. You can use isoniazid by itself with vitamin B6 once a day for 9 months. That is the longest duration. Again, liver toxicity is a big thing. So on all of these regimens, we recommend people avoid alcohol while they're on it, because that can magnify the risk of liver toxicity. And then, the one I find myself using a lot is rifampin, is for 4 months. And this is basically like the only indication for rifampin monotherapy that there exists out there, almost the only indication. And so that's 600 milligrams of rifampin once a day for 4 months. And that has very high, completion rates. People usually do okay. And then especially younger folks and people of military age, they do all right. Rifampin, again, some liver toxicity, not usually a big deal, but we do recommend people avoid or at least minimize alcohol consumption. Rifampin has a ton of other drug interactions. So this is not likely to be relevant to someone who in the deployed military, but people who are on statins, people who are on certain blood pressure medications like amlodipine and nifedipine, there can be significant interactions. Flomax is one, which is for people who are for their prostates. Again, not necessarily as relevant to the deployed military. So rifampin in a young person who doesn't take any other meds, it's usually not a big deal. The other thing, it's not really a bad side effect, but I just have to warn people about it, is when you take rifampin, all of your body fluids, including your urine, turn kind of a festive reddish color. And so when you take rifampin, you start peeing red. And I do have to warn people in advance, it's harmless, it's benign, it's not hurting you. But if I don't tell you about it in advance, I'm going to get a very panicky call in a few days. So, yeah. Yes. But that can also apply like sweat. So if you're like, if you're wearing a white t-shirt and you're out in the hot sun and you're sweating, your sweat stains may be kind of reddish, orangish as well.
So that was kind of the syndromes, I guess, that come with latent TB. What about active? Yeah,
so for active TB, again, we have a 4-drug regimen up front. So RIPE, which in the deployed environment is, I think, the only one you're likely to see. Again, you have multiple drugs there. You have the rifampin and the isoniazid, plus pyrazinamide and ethambutol. Rifampin and isoniazid, again, have liver toxicity, and that toxicity is somewhat additive. I said I pretty much never stop. I very rarely have to stop latent TB therapy because of liver issues. I do occasionally have to pause active TB therapy because of liver issues. But actually the one that is the most hepatotoxic in the 4 is actually the pyrazinamide. That is the most hepatotoxic of the group. And so often when we get into problems with liver toxicity, people who have LFT elevations, they have jaundice, they have belly pain, we stop all the drugs and then we reintroduce them one at a time. And usually the pyrazinamide is the culprit, to be honest with you. Pyrazinamide can also cause some joint discomfort. That's not terribly common in younger people, a little more common in older folks. And then ethambutol is a pretty benign drug. It does have some ocular toxicity, some retinal toxicity that can manifest as loss of color vision. Remember those Ishihara plates you use for color? Yeah, so that's part of the screening process for that. That is not an emergency to get that done, but I do try to get people seen by an ophthalmologist at some point early in their TB therapy, just to establish a baseline and see what kind of screening we need to do in the future while they're on ethambutol. In general, people are usually not on ethambutol more than a couple months. And so it's almost never a long-term issue. It can be more of an issue with some of the, what we call the non-tuberculous mycobacteria, like Mycobacterium avium, where they're on ethambutol much longer. That's a little bit, those are probably less operationally relevant infections, but come up in my line of work a good bit.
Another question I had. So wading into a tuberculosis outbreak is not my idea of an awesome time.
It's not ideal.
I'm a little bit busy.
Yeah.
So I recognize a person.
Yeah.
I believe, or we figured out this person has tuberculosis.
Right.
You obviously are going to want to report this higher.
Yeah.
Right.
Mm-hmm.
Whether it be through the military channels. What about, NGOs or things like that? Who or how would they start to report this stuff up?
Yeah, I mean, so most of the time this is going to be through, depending on the nature of the country you're in, this is going to be, we want to let, whatever preventive medicine, public health authority is over your unit be aware. And they can often provide a lot of very good guidance. And tuberculosis control is one of those things where military public health is pretty tightly attuned to. In terms of, kind of our obligations to our host countries, generally this is one of those things that most ministries of health or departments of health will pay a lot of attention to. Depending on, the nature of your relationship, some of the bigger NGOs are very engaged in this. If you happen to be around a place with like a Gates Foundation group or some of the other larger international groups, within the U.S., PEPFAR has played a big role in TB control because of their work in HIV. In terms of other larger groups like MSF, the Doctors Without Borders, Médecins Sans Frontières, they will in many cases have access to TB diagnostics. But like when I was in Ghana, a lot of very small hospitals would have good access to rapid TB diagnostics, and these are actually pretty widespread in many parts of the world. And I think part of the reason that a lot of us in the U.S. don't have as much awareness of it, and we don't always have our TB PCR set up, is because we don't have that much TB, relatively speaking. We have those technologies, we have those machines, we have them in my hospital, we have them in lots of hospitals, but it doesn't come up quite as often for us. But there will often the local NGOs or the local ministry can tell you where you can send a sputum sample, and they can run it pretty fast.
Okay, perfect. When it comes to tuberculosis or treatment or whatever, is there anything else that we need to put out?
I would say just the first things I would say is keep calm, right? Keep calm. TB is a long-term issue. I would say that as an ID doctor, I find treating tuberculosis very satisfying, right? That the majority of people get better. They're often very sick, and they do a lot better. And I was actually reminded of a man I took care of back in San Diego, who was a merchant Marine who showed up in our emergency department with just multiple pulmonary nodules and a big pleural effusion. And our ED gave me a call, and I brought him up to my office, and we did a thoracentesis and got some specimens. The things I was worried about in San Diego with this guy is he has TB, he has cocci, or he has cancer, right? And when finally when the assays came back and it was all tuberculosis, I bring him and his wife come into my office, and I tell them, "Well, sir, you have TB," and they are very tearful, and I'm like, "Whoa. This is great news. You are going to be fine," right? Like, because if it was disseminated coccidioidomycosis, he was going to be on therapy for a very, very long time. And if it was cancer, it was widely metastatic, and he'd be dead, right? But TB, TB I can fix. And we got him on therapy. A month later, he's feeling better. 6 months later, he's cured, right? And it was kind of funny. It turned out that his tuberculosis was the only thing controlling his weight, because he promptly gained 50 pounds when I cured his TB. But he did great, right? And that has usually been my experience with TB. But I also didn't admit this guy to the hospital, right? I didn't, it wasn't, I did this over the course of a couple of weeks. We worked him up over the course of a couple of weeks, got him on therapy, did all this testing. It was expedited, but it wasn't the crashing and burning. And I said, I've been exposed to TB more times than I can count. And I have always been negative. I have never converted my PPD. I've never converted my quantiferon, right? That doesn't mean there's no risk. Obviously, there's risk. It wouldn't be a global pandemic if it weren't. But the risk to the individual is not that high. It takes prolonged exposure to really for that risk to start to add up. If you know that you were exposed to a person with active tuberculosis, we get some sort of latent TB screening test done up front to establish a baseline, then we repeat it in a few months to see if you convert. Because again, most of that risk of latent TB is in the first year. And so we establish in the first year, if you convert, we get you on active therapy, and most people do very well. So the risk to the individual clinician, the individual service member is not that high, but it does require follow-up, right? So I tell people, don't panic. Do your follow-up. Make sure you're okay. Make sure your chest x-ray is okay. We monitor you for symptoms. But, the great majority of people with latent TB are fine. And the great majority of people with active TB do recover when given access to effective therapy. And I have one other little anecdote that, back in the Navy, we had a case of active tuberculosis with hemoptysis, not a lot of hemoptysis, but with some hemoptysis among a member of our hospital staff, who was born overseas. Anyway, so I see him, I get him on treatment. And this young, he was an officer, and had exposure to patients. And we actually screened all of his patients, and none of them had converted, because again, the risk is not that high with brief contact, and got him on therapy and cured, did great. About 9 months later, I was paired up with him. We were running a PRT at the same time. And so he and I paired up, right? And so for counting each other's sit-ups and push-ups and all that. And this dude smoked me. Just absolutely just laid waste to my PRT score. He's maxing out his sit-ups, maxing out his push-ups. He's faster than me. So as a doctor, very satisfying, right? As a somewhat competitive dude, a little less satisfying. But it just shows that, that people generally do well. But the barriers to people doing well in TB are related to things like access to HIV care, access to early diagnosis, existence of comorbidities. Those are the things that increase the odds of mortality. Most people do very well. Yeah. Yeah.
Well, thank you, Ryan. I really appreciate you coming on.
It's always a pleasure, my friend. Thank you for having me.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.